It's very exciting always to talk about CTAK and in particular to talk about how the Z8 laser really makes the CTAK experience much easier and also much more predictable. So always like to start with the timeline of CTAK. CTAK actually started in 2015. Dr. Peter Hirsch in our practice in Teaneck, New Jersey, did the first procedure. And it's gone through a few different iterations with our partnership with both CorneaGen and Zimmer starting in 2020 and 2021, giving us the ability to use the vision graft tissue with the Z8 laser to really create a amazing CTAK experience. So the evolution of CTAK started, as I said, about 2015, and we started actually with inlays that we had placed in the cornea. These were inlays that covered the pupil. We were actually at the time shaping them with the excimer laser. And as you can see in the picture in the bottom left, we were getting excellent topographic results. We were getting a significant amount of flattening in the cornea. And you can see from the picture in the middle, the very advanced keratoconus looking topographically much better. One of the things that we were noticing, though, was that we really were not getting visual results that were comparable with the results we were seeing on topography. So we shifted to visual axis sparing inlays. We essentially used the same inlay format, punched a hole in the center, creating a donut shape to the inlay. And what we noticed was that, again, we were getting very good, very reproducible topography. Very similar here, as you can see, this very significant central flattening with a more regular postoperative appearance. And now we were starting to see that the vision was actually catching up with the topography that we were seeing. By sparing the visual axis, we were able to get excellent visual results. And really what gives us the ability to achieve this precision is both our partnership with CorneaGen that allows us to use preserved corneal tissue, which is shelf-stable for 2 years, and our partnership with Zimmer, which allows us to cut these inlays in an incredibly precise fashion. And really what makes CTAK special is what we kind of like to call now the CTAK ecosystem. We can take corneal topography, we can then upload that topography and send it to CorneaGen. A plan can then be provided for you, which shows the cut of the inlay, the specifications of the inlay, but also where to place the inlay. The tissue is prepared on the Z8 laser to those exact specifications, and then it can be placed in your OR or laser suite. So does that preparation matter? Does it matter that we're able to get such precise cuts with the Z8 laser? Well, if you look here at the slide here on the left, you can see this was one of the original CTAK inlays that were done. This is with a more manual cut. And then the picture on the right is after a femtosecond cut CTAK inlay tissue. And really the picture on the right, you can see, you can barely even find that inlay 1 year later. So the precision of these cuts really makes a beautiful inlay to place in patients. We published our initial results in JCRS, and we published our prospective trial on 21 eyes of 18 patients. And you can see really the visual improvement with these inlays was profound. So one of the most amazing things about CTAK is how much visual improvement keratoconus patients are getting. There's nothing out there that can give a keratoconus patient this much improvement and also this quickly. With uncorrected vision, we are seeing that the average improvement was about 6 lines of correction from about 2230 to 2080. And over 10 patients improved by over 6 lines of vision after they had the CTAK procedure. If we looked at corrected vision, so this was particularly vision in glasses, we saw that the average improvement was about 3 lines of correction. And so that was an improvement from about 2080 to 2040. And this is a really meaningful improvement for our keratoconus patients, because if they can get a glasses correction of 20/40, they actually become very, very functional in their glasses. It doesn't mean that every patient is not going to wear their contact lens or choose to wear their lens on a regular basis for the things they do, but it gives patients the ability in more severe cases to take their lens out at night, to take breaks of wearing their lens over the weekend, and not feel paralyzed that they can't function. So these are real meaningful changes for these keratoconus patients. This was really an amazing thing we found, because there's really no other procedure for keratoconus that we were able to measurably see an improvement in spectacle correction, in the actual refraction. And what we saw was that patients improved from about 6 diopters preoperatively to almost 1.5 diopters of myopia at about 6 months after their CTAK procedure. This is a huge improvement in their spherical equivalent and in their glasses prescription, and really goes to show why patients are appreciating the difference when they wear glasses. From a topography standpoint, we were seeing an average flattening of just over 8 diopters of the mean keratometry and about 7 diopters of maximum keratometry. But really, when it comes to CTAK, the difference is in the diverse amount of flattening that we were able to achieve. So not every patient needs to have a maximum amount of flattening achieved with each inlay. It's about getting the right flattening for the right patient. And this is really where the Z8 using the femto laser shines in preparing this tissue. Using the femto laser gives us the ability to cut these inlays at 50 micron increments, which really gives us a precision to how flat we can make each cornea postoperatively. And so for more mild cases, we can induce small amounts of flattening, and then in our more severe cases, we can induce a maximum amount of flattening. So in our study, we were seeing a flattening that ranged anywhere from just under 4 diopters to as much as almost 30 diopters, depending on what thickness we used. Additionally, if you look at the post-operative maps right in the center, the top shows a severe keratoconus patient, the middle a more moderate, and the bottom a more mild case. And what I really want to draw your attention to is that middle post-operative column, because what you can see is there's a reproducible flattening where you get this more regular astigmatism centrally, no matter where the starting point is. That is really the magic of CTAK. The magic of CTAK is seeing that reproducible flattening right in the center, no matter where the starting point begins. So as I said, it starts with the planning. The ability to upload topography to CorneaGen and then receive a surgical plan is what allows us to get these reproducible results for each of our keratoconus patients. And this planning software is going to be coming out hopefully shortly on the Galilei system, where you'll be able to select for a keratoconus patient that you want CTAK planning to be done. You'll take a very quick scan on the Galilei, and then that scan can be uploaded directly from the system to CorneaGen to receive a plan. Now that plan comes with a few different specifications to it. It will come with an inner diameter, an outer diameter, a thickness, and a length, an arc length of the inlay. Now all of these are actually adjustable, so each surgeon has the choice to adjust these inlays however they choose. But mostly when surgeons start, they start with the plans that they get, and then like any procedure, as it goes on, you might learn how you want to make certain adjustments on your own. One of the adjustments that we see frequently made is in the thickness parameter. So when you sometimes have a more myopic patient and you're looking to maybe induce a little bit more flattening just to get a more refractive result, you might increase the thickness a little more than the software recommends because you actually want to get more flattening to get a further improvement of the myopia. You can change the length, although we haven't seen much change in that, and the inner diameter as well. Although I would use caution at changing any of those specifications until you have done multiple of these procedures. We've developed with Corza an instrument set, which really does make placing these inlays much easier. You're able to grip the tissue, place the tissue, smooth it, and manipulate it much easier than in the past. And as we'll see with the Z8 laser, you're able to create channels which really make that process Very, very straightforward. Now, the Z8 laser has a couple of advantages to it, and we'll go over its cutting advantages in just a bit. But one of the big advantages, which I'll talk more about also tomorrow, is really the size of the Z8 footprint. The footprint of the Z8 really allows it to fit in almost any laser suite. So I work in New Jersey. We don't have as much size in our office space. And as you can see here, we're able to fit the Z8 in the same space as our excimer laser and not have to move the patient back and forth to different beds to be able to make the channel and then also place the tissue. You can roll the laser into the operating room and make the channel and do the CTAK inlay all at once, which is very helpful because if you're doing CTAK in the operating room, which can be important for certain reimbursement reasons, you're able to do it all in one shot without moving the patient to different rooms or even moving the patient between different locations. So this can be really, really helpful in all of your workflow with CTAK, with cataract surgery, really with anything that the Z8 laser can do. So getting to the procedure itself, marking the tissue, marking the cornea is really, really important to get the laser lined up to make the channel in the proper position. And one of the most important things you get from the surgical plan is a marking position. So you get an inferior position, a temporal position, and an infratemporal position, which you then mark and can encircle with a zone marker at 4 or 4.5 or now 5 millimeters, which can then give you the place to line your femto laser up to create your channel. So one of the nice things in the Z8 is actually the very wide ring that you get with the patient interface. So you have the ability to place a 10 millimeter ring on the patient's cornea, which really gives you the ability to move your channel peripherally if you need to get this really very well lined up with the markings that you create. And some of these CTAK inlays can be fairly central, but others can move more peripheral. And the key is really getting your channel lined up properly. The success of the inlay is really in the placement of that channel because that is what is going to create the entire flattening effect. So having significant flexibility in that is very, very important. Some of the other really nice features about the Z8, besides being able to move the inlay into position, is you can actually create a channel to the exact specifications of the plan. So you don't have to create a 360-degree channel. You can create a channel to the exact length of the inlay, leaving a little room on each side for the incisions. You can create 2 incisions, which allows you to work from both ends to both push the inlay into position and pull. And also you have the ability to align and for cyclotorsion. So I will now mark the area of the axis on the cornea, and then I will use the Zimmer software to actually align and account for any cyclotorsion that might happen, which really increases the accuracy of this inlay placement. So here's a case of placing the inlay into position. We start with the marking. Again, I only mark now inferiorly and temporally, and then encompass that mark with our optical zone marker. You really want to make a dense mark. So we're usually afraid to mark the cornea that we think it's going to affect the femto cut. But here you really want a dense mark so you can make that cut. Then we open the incision with really a LASIK dissector. It's a 200 micron deep incision, so it's pretty easy to open in that way. Very important to fully dissect the channel. So you need to really make sure you don't have any adhesions because the inlay is soft. So unlike synthetic inlays, it's not going to push through any adhesions. And then with the CTAK forceps, we're easily able to grip the forceps. We try to grip it close to the edge, place it right through the incision, and then place it into the channel where we can push it and smooth it out into position. It's really the incision that's created actually by the Z8 has a really, really great form to it, which allows you to get a lot of manipulation in it without damaging any of the incision area. And then we smooth out the inlay, and then that's pretty much it. So this video got a little slowed down, but one of the real advantages is having the 2 incisions to work with. So we can first place the inlay through the incision and get it into position, kind of push it along the way as far as we can. These tissues do not have to be dehydrated. So because of the gamma irradiation process, they have some rigidity to them, and you're able to, you don't have to wait to place them in the channel. And now you can see we're almost there. We've almost reached the point of the final placement of the inlay, but we can now take the manipulator through the second incision and really bring the inlay around. So when you're working in a 360-degree channel, you can do this, but you're constantly having to kind of manipulate your instruments where you have to reach around the channel to get to it, even for pushing or puller. With two incisions, you really have a nice, easy trajectory with your instruments to get the inlay into position very quickly. Now, for standard cases, that 360-degree difference versus the two incisions is very helpful, but can be done. But for some of the more intricate cases that we do, the two incisions can be incredibly helpful. And really, they can take the more complex CTAK cases and really make them into more regular, straightforward procedures. So this was a case of a 38-year-old male. He had a transplant in one eye, and then he had intacts placed in his other eye to hopefully correct his vision. And he was very unhappy after his intacts was placed, and you can see why. So all of us have had this experience with intacts where many times it worked very, very well, but there were cases where you would place them and it was just not predictable, and the vision would not necessarily improve. Now, his case, his vision actually got slightly worse. So after his intacts placement, his vision dropped from 2200 to actually 2400, and his refraction actually got worse. He became more myopic. So this patient was very unhappy with their intact segment. And so we offered him to take out the intact segment and actually replace it with a CTAK. And we've started to do this more and more. So one of the important things, though, when you're going to take out an intact segment and then replace it with a CTAK is trying to plan for your incisions. Because all of a sudden, going through multiple procedures, the cornea is going to have multiple incisions on it. So this was actually a different patient's cornea, but you can see highlighted in orange there, that's the original intacts incision. So generally, we don't go back through those incisions to take the intacts out. And normally, I try to make an incision that's right next to the intacts inlay to facilitate taking it out very easily. But in these cases, you actually don't want to do that. So here, I try to make a new incision as close to the old incision as possible to leave us with a lot of room for the new CTAK inlay. And then I try to redissect the channel and bring the intacts out through that channel. I then let the patient wait for a month. I let the topography stabilize, retake the topography to get a new plan, and then go ahead with CTAK placement. So this is the patient. And now, as we discussed, so he has two incisions, one that was placed for the original intacts, one to remove it. And the nice thing with the Z8 is I can now place a third incision where I can place it exactly where I want it. So I still can maintain the two incision approach, both being able to push the inlay into position and to pull the inlay into position. And that's the third incision in blue. So you can imagine if you have a 360-degree channel and you're trying to navigate through all these old incisions, that becomes very, very challenging and much harder to place these inlays exactly where they need to be. But here, I can take a much more complicated case and make it just like any other inlay that we place. And now you can see how much better he's doing with the CTAK. So his vision now improved from 2400 with the intacts, 2200 pre-op, to actually 2060 in glasses after he had the CTAK placed, and a much better refraction. So this patient is much happier with the CTAK placement. Another case that comes up is what do we do after LASIK? So with our cases of ectasia after LASIK, these also can be more complicated because the corneas tend to be very, very thin in these cases. You've had a cornea now that's had an excimer ablation done, typically a myopic ablation. Now they're thinning further because of the ectatic process and the ectasia that's happening. And we now have to navigate placing this larger inlay underneath the LASIK flap and still within position to get a flattening effect. And we try to find kind of where's the right spot to place them. 200 microns tends to be too shallow. You will get the inlay kind of frequently kind of stuck in sometimes the LASIK interface. So we generally recommend that we go deeper in the cornea. And we'll say to go to 250, and a lot of surgeons feel more comfortable going to 300 microns. But as you push down on that depth, these inlays are sitting much more central than your typical synthetic inlays used to sit. So knowing how deep you can go in the cornea really becomes very important. And here's where the built-in OCT can be very, very helpful. So I do not run an OCT on every CTAK that I do, but on the CTAKs after LASIK, this can be very, very helpful. Because as you can see here, if you see the line going across where the channel is going to be created, here I might say, well, this is actually a little bit too deep. I'm concerned right in the center that we're going to be too close to the endothelium. And you can, on the spot, lift the channel more anteriorly and get it underneath the LASIK flap, above the endothelium, and get a cut right where you want it to be. So in this case, the OCT can actually save you from placing the inlay too deep or even making a potential perforation in a very thin cornea. I showed this case as an interesting case, both to show how wide-ranging the CTAK can be, but also to show kind of the integrity of the channels that you get with the Z8 laser. So this was an interesting case because this patient was a 25-year-old male. It seemed pretty straightforward to me. He came in for CTAK and placed the CTAK inlay. And actually, in the first month when we saw him back, he was doing slightly worse. So his uncorrected vision had dropped to 2100 and his corrected vision from 2030 to 2040. And so he didn't feel like the CTAK really helped at all. And if anything, he thought it maybe was a little bit worse. And when I looked at his topography, it looked to me like the inlay had flattened slightly too much nasally, and we were getting too much flattening in a position where the cornea was already flat. So because this inlay is made of corneal tissue, I felt that I could reduce the flattening nasally by just shortening it. So 1 month later, we reopened the incision, placed some BSS to separate it from the anterior and posterior lamellae. We used the manipulator to bring the CTAK inlay out of the incision. And you can see I marked where now I want the inlay to line up. So I bring it out slightly past that mark. And then I trimmed it with a Westcott scissors. And then advanced it back just so it would go to that nasal mark. My feeling here was that if we could decrease how much the inlay was positioned nasally, we'd be able to get a better effect. So again, you can see even in a case where the CTAK inlay didn't perform quite in the way that I wanted it to, unlike synthetic inlays, I had the ability to fix this for the patient, and his vision then improved from 20/70 uncorrected to 20/50 and from 20/30 in glasses to 20/20. So even in a case that didn't go quite as planned, the CTAK really gives you the ability to do a lot of diverse treatment for our keratoconus patients. So hopefully over this talk, you can see the CTAK is really a very customized inlay for keratoconus patients. There's really nothing out there that can take both mild cases, moderate cases, and more severe cases and really treat it reproducibly with the same effect. The precision of the Z8 cutting really allows you to place the channels exactly where you want them to be, but also the incisions account for cyclotorsion and place 2 separate incisions, making this procedure really, really straightforward. It can increase efficiency because of its footprint, being able to use it in the OR or really any size laser suite. And it takes the complex cases. It can take the cases that make us more hesitant to do CTAK or more concerned about doing the case and really make them just like doing any other procedure. Thank you for your time.